Okay, so let's just kind of summarize so that we can review how we actually set this up. So when we go through our competencies and practicals, how do we do this? So the effects that we get with ultrasound are really based on whether we want thermal or non-thermal effects. So those thermal settings, right, are going to be all of our same effects that we talked about with our superficial heat. We're just talking deeper. So decreased pain perception, increased metabolism, increased blood flow. We could also get the increased vasoelectric activity. So then our non-thermal effects, right, would be our tissue regeneration, the wound healing, cell membrane alterations, the cavitation, microstreaming, changing those kind of situations on the cell and kind of promoting us moving into the proliferation phase and promoting all those things within the proliferation phase. Now remember again, every time we have ultrasound on, we get both of these things happening. If we have settings high enough, we'll maximize the thermal effects. If we have our settings low enough and with duty cycles, we will minimize thermal, which allows us to maximize non-thermal. So advantages of ultrasound, we get to heat deep tissues. We get all these healing benefits from our non-thermal effects. Disadvantages, we have to only use that small area, right? So we're 2 to 3 times the ERA. The machine variability and patient responses are very different to ultrasound. The tissue we're trying to target, the BNRs, some of those limitations might cause some disadvantages. So indications, all these different things depending again, thermal or non-thermal. So an indication, we would use it for acute / post-acute. If they're in that inflammatory stage, we'd stick with the non-thermal. Anytime we want soft tissue healing and repair, anytime we want to potentially decrease some scar tissue, right? The cavitation helps break up and loosen up some of that scar tissue. Joint contractures, that would be more of our thermal and especially our vigorous heating from our thermal. The chronic inflammation was more of our moderate level heating. The extensibility of collagen kind of goes with the joint contractures, the decreased muscle spasms and pain modulation. Also went with our moderate heating. Increased blood flow happened also with our moderate heating. The increased protein synthesis, that comes both from the non-thermal and thermal effects. Tissue regeneration is the non-thermal. We have the bone healing, so non-union fractures and bone healing. That was specific types of ultrasound, right? Our low intensity, kind of low frequency ultrasound. Inflammation from myositis ossificans and other sorts of like hematoma resolutions. It's even been used on like Plantar's warts. Myofascial trigger points, especially the heating, especially then thinking of that with combo for that, or muscle spasms would also be good indications. Our contraindications, if we were using thermal, acute and post-acute would be contraindicated. And then it's all of our typical kind of contraindications we've had for our modalities yet so far, right? Vascular insufficiency, thrombophlebitis, if they have infections or malignancies, so cancers, pacemakers, we don't want to go over any fluid-filled organs, pregnancy, over the pelvis during menstruation, if they have any decreased sensations in those areas, we have that kind of down here in precautions, decreased sensation, decreased circulation. Metal implants, remember I talked about the epiphyseal areas, how research is out on that, doesn't seem to be an issue. I would even move the total joint replacements up here to the contraindications because of the cement. If there's cement, joint cement in there, that's going to absorb the heat too much, and that's going to be a contraindication. So then on to our competency, right? Our pre-application steps. Make sure you've diagnosed the injury properly. You set up your goals and you match the indications that from our list to those goals. You check your contraindications. You do some sort of patient-oriented measure, pain scales, functional, whatever you want to do for that. Prepare the patient psychologically, so explain the procedure. If we're doing heating thermal ultrasound, they should just experience gentle warmth. They shouldn't have any problems with pain with that. If there is pain, we want to explain to them to let us know, but not to pull their leg away, right? We don't want to expose the ultrasound head to the air. So we will just move up to kind of a beefier part of the body, especially if we were going over superficial bone or things like that, and let that area cool down a little bit and then come back. We would move our ultrasound head a little bit faster, maybe turn down our intensity, and then increase our time to keep up with our same goals of reaching the right therapeutic temperature. But we never want to have them pull away. So we can shut it off if they don't even want us to keep going, but we don't want to pull that ultrasound head away. But we want to tell them that, if you experience any like significant heat or any pain, to let us know. We can offer to demonstrate on ourselves, check all of the precautions. Then we can prepare the patient physically, so make sure they're comfortable. We got to remove any metal or jewelry in the area. We want to remove the clothing because the gel will be messy, especially if we're doing underwater ultrasound. Want to make sure there's no open wounds or rashes, or if they are, we want to cover those. One, we want to make sure there's not any infections, right? That would be a contraindication. But otherwise, we can cover those with like a tegaderm or a occlusive dressing and do the ultrasound treatment kind of around that area. Make sure that the patient is positioned properly. Again, if we're trying to do some of that vigorous heating, or if it's for muscle spasms or trigger points, we might want to be able to put that tissue on a stretch while we're doing the ultrasound. So thinking about how we can position them so that they're both comfortable, but that we can put that stretch on it. Then we prepare the equipment. So make sure the sound head is clean. Also clean the skin, apply the coupling agent that we're going to use. And then we set up our applications, so set up our parameters. So you pick your frequency, which is based on our depth. You decide your duty cycle, continuous or pulse, depending on if we want thermal, non-thermal. Our intensity is based on the goals, based on what we need to get to our heating level, based on our BNR. So you'd also want to check before, I would put that back here in preparing the equipment, check your ERA and check your BNR if you don't know those right away. And then adjust that intensity based on the goals and the patient's perception of heat. So if they're not experiencing any heat after several minutes where the temp should be rising, we might want to increase our intensity. Or if they're experiencing too much heat, we might want to decrease a little bit. But again, that always affects then our length of application. So if we're doing thermal, it depends on our chart. We set our treatment time. Non-thermal is somewhere between 5 to 10 minutes. Again, I usually like closer to 8. We move the sound head at about 3 to 4 centimeters per second for no more of an area than 2 to 3 times the ERA. We can do it 1 to 2 times a day. Again, acute was maybe twice a day for about a week. More of our chronic heatings, we would maybe do 1 treatment every other day for up to like 14 treatments. Again, we want to note that we're making progress, and if we're not making progress, after 4 to 5 treatments, we maybe want to reconsider, look at our parameters, set something different, or maybe consider a different ultrasound. For sure, after 14 treatments, if we have plateaued, it's time to try something else. Then post-application steps, clean your sound head, replace it, ask about the patient-oriented outcome measure again, whether you're doing global rate of change or whatever it might be. Give instructions, so what are those self-treatments and home treatments? Schedule their next treatment or appointment. Are there exercises they should be doing? What is their level of participation at this moment? And then we document. And then maintenance is annual calibration. We also always want to check our cords, make sure they're all in order, make sure the sound head isn't cracked or anything like that. Finally, if we're talking about phonophoresis application, it's mainly our same steps. Now, because we're trying to get the medication in, we really want to make sure the area is clean, it's shaved of hair, and that we potentially even debride. So take a little emery paper or an emery board and kind of rough up the skin a little bit, get some of that stratum corneum off, all that dead skin. We can preheat the treatment area. That helps decrease the skin resistance and increase the absorption. So 15 minutes with a heat pack can sometimes help that. Position the extremity to encourage circulation. So we want to make sure that we're not cutting off circulation or that we're in a really dependent position so that the body part wouldn't have a lot of circulation to circulate the medication around. We apply the medication directly over the targeted tissues. We apply a pretty liberal amount of ultrasound gel over the medication, so usually we have rubbed that in, or we potentially do the rub it in, put some ultrasound gel down, cover with an occlusive dressing, and then put more ultrasound gel down and do the ultrasound over that. Sometimes it's even beneficial to rub it into the skin and let it pre-absorb for about 30 minutes. So you could rub it in, have them do that ahead of time. Maybe then they come heat for a little bit, and then we do the ultrasound. It just kind of depends on the medication. You'd want to talk to your physician about that. Follow the procedures described in our ultrasound and settings and all of that. Typically, we use our ultrasound at a 50% or 100% duty cycle. and we keep our output somewhere between 1 to 2. Again, if we're doing anti-inflammatories, I like to do a 50% at maybe, trying to keep it below, or sorry, I'd like to do 100%, maybe actually keeping it down at like 0.2, so that we don't get any heating if our goal was to do anti-inflammatory. Same thing then, we wouldn't preheat the area either if we're trying to do an anti-inflammatory drug, because they're just kind of contradicting to each other. If we use that occlusive dressing after the treatment, we can leave that on and let that stay in place so the medication can continue to absorb into the skin for 15 minutes after the treatment as well.